Thanks for tuning in. My name's Colleen Miller, and I'm a registered dietitian. It's my pleasure to be able to present as part of the Trending Now series on the topic of celiac disease and gluten sensitivity. I thank you for tuning in today and hope you enjoy this presentation. I have no financial disclosures to reveal at the time this presentation was recorded. I do own and operate a virtual private practice based out of Ontario, Canada, with a focus on supporting clients who have digestive health issues. Without further ado, let's take a few moments to review the objectives of this presentation and then dive on in further. There are three objectives of today's presentation, and by the end of viewing, you should have a clear understanding of the difference between celiac disease and gluten sensitivity, be aware of the different types of tests out there and how they support diagnosis, and have increased confidence on how to approach a conversation about this with your healthcare practitioner or with patients if you are a healthcare practitioner yourself. First, let's tackle the difference between celiac disease and gluten sensitivity. Under the larger umbrella of gluten-related disorders, we would find celiac disease, wheat allergy, and gluten sensitivity. But for today's presentation, we'll focus just on celiac disease and gluten sensitivity. Celiac disease is an autoimmune condition that affects an estimated 1% of Canadians. In celiac disease, the absorptive surface of the small intestine is damaged by the ingestion of gluten, a protein found in wheat, barley, and rye. Damage to the intestine can lead to a variety of symptoms and result in the inability to adequately absorb nutrients, as well as vitamins and minerals that are necessary for optimal health. Symptoms of celiac disease can include digestive symptoms such as diarrhea, abdominal cramping, bloating, abdominal pain, and malabsorption, but also include non-digestive symptoms such as fatigue, joint pain, and brain fog. Gluten sensitivity is the term used to describe when someone has a symptomatic reaction to the ingestion of gluten-containing foods. There has been quite a bit of interest and debate in literature about terminology and the use of term gluten sensitive, because someone who has celiac disease would be considered gluten sensitive based on their experience of symptomatic reaction to the ingestion of gluten-containing foods. Perhaps a more accurate diagnosis, and one that's more commonly used in literature of late, is the term non-celiac gluten sensitivity, which describes a person who has symptomatic reaction to the ingestion of gluten, but for whom a diagnosis of celiac disease has been ruled out. For the remainder of today's presentation, I will use the terminology non-celiac gluten sensitivity as I refer to gluten sensitivity. The prevalence is estimated for non-celiac gluten sensitivity ranges quite widely in literature, largely due to limited population studies, the evolution of definitions and terminology, and a high number of self-reported cases, but is referenced as high as 13% of the population in some studies. Therefore, it is quite a bit higher than the estimated prevalence of celiac disease in Canadians at only 1%. While it is believed that there can be immune involvement, non-celiac gluten sensitivity is not an autoimmune condition, and the degree to which gluten must be avoided, as well as consequences of accidental exposure, may differ between an individual with celiac disease and an individual with non-celiac gluten sensitivity. This next slide may help further clarify the difference between celiac disease and non-celiac gluten sensitivity. The first row of this table highlights the difference in prevalence as we've already discussed, while the second row reminds us of the fact that celiac disease is autoimmune in nature. In celiac disease, the immune system is mistakenly recognizing gluten as an invader and activating the immune system to attack the small intestine. In non-celiac gluten sensitivity, it's not fully understood what mechanisms are at play, but is recognized there may be involvement of the immune system, but it is not autoimmune in nature. The third row of this table speaks to the role of genes. Those who have celiac disease are extremely likely to have either what is known as an HLA-DQ2 or HLA-DQ8 gene. And this incidence is much higher than the chance of having this gene if you are if you have celiac disease versus if you are non-celiac gluten sensitive or have no gluten-related disorder whatsoever. Presence of either one of these genes does not equal a diagnosis of celiac disease, but absence of one or of at least one of these genes would suggest very low likelihood that someone has celiac disease. We will discuss this more in a few slides as it relates to the role of testing and diagnosing celiac disease. The row below this highlights serological markers, or those that can be tested in blood tests. There are a few tests that can screen for celiac disease via blood test. The most common blood test for screening is known as the anti-tissue transglutaminase, or TTG. This blood test is not 100% accurate and is not used on its own to diagnose celiac disease, but is commonly used as a guide, as is quite sensitive and specific for celiac disease. If the screening test were performed on someone with non-celiac gluten sensitivity, it would be expected that these results would come back negative. I won't get into too much detail on the final two rows of this table, but will highlight that due to the autoimmune nature of celiac disease, when viewed under a microscope, the cells of the small intestine of someone who lives with celiac disease will generally show a high degree of intraepithelial lymphocytes, or white blood cells, and damage to the villi in the instance where a diagnosis is being evaluated and they are consuming gluten. Whereas in non-celiac gluten sensitivity, the same test under microscope would generally reveal no villi damage and a lesser degree of intraepithelial lymphocytes. So to summarize, while the symptoms of celiac disease and non-celiac gluten sensitivity may appear very similar, a key difference is the autoimmune nature of celiac disease and resulting damage to small intestine that ensues when gluten is ingested. Non-celiac gluten sensitivity is not autoimmune in nature, and finding on endoscopy will generally suggest a milder immune response and absence of damage to the villi. The previous slide touched on this, but let's review what tests are involved in diagnosing celiac disease. The first step is generally a blood test, which must be taken while someone is on a gluten-containing diet in order to avoid a false negative result. The blood test is followed by endoscopy with small bowel biopsy. During an endoscopy, a tube is inserted via the mouth into the digestive tract so your gastroenterologist can get a visible look inside and perform a biopsy of the duodenum. A gastroenterologist may also decide to do an endoscopy with biopsy in a situation where the blood test was negative but clinical suspicion for celiac disease is high. Just like serology, an endoscopy should be performed while a patient is on a gluten-containing diet to avoid false negative test results. The genetic blood test to detect the presence of the HLA-DQ2 or HLA-DQ8 can be performed whether a patient is on a diet containing gluten or not, without concern for false negative test results. It's important to remember, however, that presence of either or both of these genes does not mean that you have or will develop celiac disease, as many people without gluten-related symptoms have these genes. If someone has already removed gluten from their diet and been off it for a long time, this test may be helpful, as a negative test result would suggest very low likelihood that this person indeed has celiac disease and would need to move on to a gluten challenge. A positive test result, on the other hand, would warrant conversation about moving on to the gluten challenge, whereby this individual would add gluten back into their diet and pursue further testing. My next few slides we're going to walk through a case study together to bring some of these concepts about testing together as we walk through an example with a patient that I recently saw in my practice. So Miss X has been following a gluten-free diet for many years. I believe it was about 5+, under the impression that she likely has celiac disease, but hasn't had any formal testing done to confirm this. She did feel better when she removed gluten from her diet and had a bit of a suspicion she had an issue with gluten because her mother does have a positive celiac diagnosis. She had reached out to me more so to just discuss nutrition counseling, sort of a nutrition checkup, make sure she was eating well, and had a few mild digestive symptoms, but her main focus was actually just wanting to get some ideas for sort of overall health and perhaps a mild weight loss goal. So my question for you is clarity on whether Miss X has celiac disease versus non-celiac gluten sensitivity needed? If you thought no, perhaps the reasons you were thinking no where, she's happy on a gluten-free diet and she's been doing this for years. It wasn't actually the reason she reached out, to talk to me about her gluten-free diet. It was sort of other pieces of her puzzle. You might have also thought no because, maybe she doesn't want to go back and start eating gluten again, which would be what would be required for a gluten challenge or to pursue some testing. Maybe you thought she's not keen on going for an endoscopy, and that would be a reasonable thought because it does happen quite often with patients. Or perhaps you thought that maybe an issue would be cost because unfortunately in the province where I live, as an example, celiac serology is not covered under OHIP and is not covered under all provincial and territorial plans in Canada. But also the genetic testing piece is very expensive and not covered under provincial plans as well. So there certainly are a few reasons here why maybe we would think, no, pursuing testing for this patient is not appropriate. Now, if you thought yes, I hope that maybe some of the answers or reasons you thought yes are on the next slide. And so there's quite a few reasons I would say, actually, yes, it might be a good idea to do proper testing with this patient. Now, it was not her intention of seeking support in the first place, but she did indicate she has these mild symptoms, and perhaps they're related to gluten exposure. In conversation with her, she indicated the digestive symptoms were mild, but she was also struggling with fatigue and joint pain and migraines, indicating possible some non-digestive symptoms as well. If indeed she has a diagnosis of celiac disease, strict adherence to a gluten-free diet would be indicated, which includes minimizing cross-contamination. It's possible, despite her best intentions, that she is being exposed to gluten. And in celiac disease, unintentional exposure to gluten can have more of an impact than just symptoms. We've already discussed the damage to the small intestine that results from the autoimmune reactions to gluten ingestion, and it's possible that this is happening sort of behind the scenes and she's not aware of it. The next point on my list here is screening implications for her children. So the risk of celiac disease for someone who has a first-degree relative, so a parent or child who has celiac disease, is estimated between 5 and 10%. Because her mother actually has a diagnosis of celiac disease, that would put her at a higher risk herself and perhaps warrant having screening done. But then indeed, if she was positive for celiac disease, would open up conversation about screening her children. Now, for Miss X, her children are actually not on gluten-free diets. They're consuming a regular diet, as she's the only one in her household on a gluten-free diet at the time. The next point on this list would be medical monitoring of other conditions. So people who have one autoimmune condition are at increased risk of getting others. And because Miss X is not being monitored as if she has a positive diagnosis of celiac disease, I would suspect things like monitoring her for thyroid disease, bone disease, etc., are not taking place, nor would things like, routine monitoring that is recommended for someone with celiac disease of things like B12, iron, and vitamin D. The last point I have on this slide is one I've more recently been discussing with clients, and that's the fact that we are closer than ever to having non-food therapies for the management of celiac disease in Canada, with several clinical trials underway and getting close to being available on sort of more mainstream. If and when therapies are approved for use in Canada that are non-food related, so for what I'm talking about here is sort of medications, I suspect there would be criteria for eligibility, and having a clear diagnosis of celiac disease is likely something that would be required in order to be eligible for such therapies. Now, in the interest of time, I won't spend too much time on this slide, but really, it shows that there are several conditions that, certainly we want to think about as far as some considerations that can be negatively impacted when adopting a gluten-free diet. So in our conversation with Ms. X, certainly I did feel some of these elements of financial burden and social deprivation came up in our conversation. But it's just important to recognize that outside of the health and nutritional implications, there are other pieces of the puzzle. And, figuring out direction on where to go with her and whether we need to tighten or potentially can relax her gluten-free diet would be helpful if we had increased clarity on what her actual diagnosis was. So my bottom line here is a person can follow a strict gluten-free diet for non-celiac gluten sensitivity, but actually must follow if the case is celiac disease with a confirmed diagnosis. And it's important to recognize that there are challenges for patients on gluten-free diets, and it's not without impact in terms of nutritional balance, but also other implications such as financial, social, etc. Decisions on to test or not to test should be informed and should respect patients' wishes. I've seen my share of clients who were interested in testing to have celiac disease ruled out as a possibility and felt quite dismissed by their healthcare practitioners. But I've also seen clients who declined testing or weren't aware of the different testing options to be able to make an informed decision whether they wanted to pursue something like genetic testing or were happier to sort of go down a different road. Having guidance with a digestive health focused dietitian can certainly help ensure a diet is balanced, whether the gluten-free diet is being followed for non-celiac gluten sensitivity or celiac disease, and helps minimize risk of nutrition deficiencies, ensure that there's adequate variety, and just help offer expertise to anyone who is pursuing this type of dietary adjustment. Dietary restriction has certainly been shown to impact the richness of the gut microbiota, something I know that is talked about in one of the other sessions as part of this series, but also something to consider that, for whatever the reason a gluten-free diet is being adopted, there certainly can be implications sort of with beyond just symptom management or sort of nutrient management, but also thinking about somebody's gut microbiota and impacts from that long-term dietary adjustment. So in summary, I wanted to touch a little bit on how to approach conversations with your healthcare practitioner, or how I hope patients would approach you if you are a healthcare practitioner. But patients should feel comfortable discussing concerns with their primary healthcare practitioner, and have confidence to even advocate for their own testing if needed, if they are concerned or have suspicion that perhaps they have celiac disease. And I say that because in Canada, the average time from the start of symptoms to diagnosis is far too long. It's over 10 years that people deal with both these digestive and non-digestive symptoms before actually having adequate tests and land on a proper diagnosis. It's important to rule out whether there's something else going on. It's possible that we're talking about celiac versus non-celiac gluten sensitivity, but there are other digestive conditions that have similar symptom profiles, and it's really important to work with your healthcare practitioner to figure out what's happening. This brings me to a question that actually was sent through before the recording of this presentation. And it was a question from somebody asking about, if you have confirmed celiac disease on a gluten-free diet, why would nausea persist? Why is that symptom persisting? And so with the limited info I have, it's hard to answer this question really in depth, but thinking back to the case we just discussed with Ms. X, I would probably wonder, is there accidental exposure that's occurring, right? It really takes very, very minimal amounts of exposure to be illicit symptoms for some patients. So that would be one question. I'd also probably wonder, how long has this person been on a gluten-free diet? And is there still some gut healing that's happening there? Or are we talking someone who's been many, many years? And I think it ties well to this slide here around the importance of seeking clarity on what's going on. It certainly is possible to have more than one digestive health issue. I can say I've worked with clients who have celiac disease as well as a diagnosis of inflammatory bowel disease, or who have celiac disease and IBS. So it's possible, one piece of the puzzle is still sort of outstanding and hasn't been fully identified. So I hope that sort of answers your question, or at least provides some food for thought about next steps and direction. Now, just going back to this one more time, we've talked a little bit about different testing options if you are trying to get that confirmation of celiac disease as a diagnosis, or to exclude celiac disease and therefore be confident that what you are facing is non-celiac gluten sensitivity. The duration and extent of how much gluten has been removed from diet matters in terms of testing options. So if gluten has been removed long-standing and quite significantly, high chances of false negative results on serology and endoscopy, so may not be the best route for testing. There may be a role for that genetic testing that we discussed, although recognizing that a positive genetic test does not confirm the diagnosis, but certainly a negative genetic test would strongly support that this is not celiac disease. And then we're recognizing the role of the gluten challenge, which we did not talk too much about today. And there has been, some recent, I guess, evolution in terms of what the length of a gluten challenge needs to be and how much gluten challenge we're talking about, which certainly makes it a little more perhaps easy for some patients to consider resuming gluten if they do feel quite unwell when they are on it. I've just put this slide here just for a little bit of a reference. There's some great materials on the Canadian Celiac Association website, one of which is these guidelines here for family physicians about what and when should be followed for someone with celiac disease. So again, if I think back to Miss X in our case study, clearly without an actual confirmed diagnosis, these things aren't being followed. But many of these things would likely need to be followed, even if somebody is not confirmed celiac disease, but does have a gluten-free diet. So screening for deficiencies may be required, even if it is just non-celiac gluten sensitivity. If there is concerns about, an unbalanced diet or inadequate absorption for some reason. And so finally, there are some wonderful materials out there as well on the Canadian Digestive Health website and social media platforms that kind of go through, more layers to this conversation. Certainly in a 20-minute presentation today, we didn't get to talk about everything we could on this topic, but you can also, find me for more information online, or follow me on social media if you're interested. I'm on Instagram at Digestive Issues Nutritionist. Actually, it's digestive.issues.nutritionist. You can find me online. I do focus primarily on adult digestive health issues in my practice, and do post some tips and tricks on my platforms when able, in between time doing presentations like this and supporting clients individually in my practice. So again, thank you so much for tuning in today. I hope that you picked up some pearls and some new food for thought, no pun intended, and that I also hope you enjoy taking a peek at the other presentations as part of this series, because it's just a wonderful mix of some great reviews of new trends and things out there. So thank you so much, and take care.